Good. People have a lot of grace and patience these days. It's all good.
Yeah.
And
That's
I
the
am
best part.
seeing, yeah, I am seeing Dr. Krupinski has joined us, and she's part of the organization that's funding the New Mexico Telehealth Alliance for these presentations. Okay, all right.
And you can see the presentation?
Yep.
Excellent.
Can't see me anymore.
All right, do we do a countdown? Are we ready?
If you go out of full screen mode, you'll see more people at the top. When you're in full screen mode, it only shows you the person who's speaking.
Yeah.
But if you just get out of full screen, you get a little bit more of a view of the people.
Okay.
Well, I'm on my iPad. That's
Hmm.
why I'm not seeing anything. Okay.
All right. Well, we've got 22 people waiting, and I'm going to go ahead and admit everybody. Are we ready? All right, let's go. All are being admitted.
Go.
You can go ahead, Bob.
Okay. Well, welcome everyone. Thanks for us this morning. Welcome to the New Mexico Telehealth Alliance educational series. This 10-week webinar focuses on various telehealth related topics. The series is made possible through funding provided by the HIPAA and the Office Advancement of Telehealth. Bob Longstreet, I'm a board member of the New Mexico Telehealth Alliance and with the New Mexico Primary Association. Today, we're going to have Michael Herrick presenting HIPAA still applies, safeguarding patient data in a work from anywhere world. Michael is a health tech serial entrepreneur with more than 25 years in technology, and he is CEO of Matterform. And a little housekeeping here, folks can take a look at the slide. Everybody, we're going to have this webinar recorded. Everybody writes on mute. We're going to do question in the chat, I believe. Is that correct?
Yes.
Yes. Final bullet point there. I finally read ahead. So I guess without further ado, Michael.
Super. Bob, thank you very much. Thank you to the Telehealth Alliance. Thank you to HIPAA. Thank you to the Office for the Advancement of Telehealth. It's great to be here with you today. It's a pleasure to be talking with all of you. Yeah, I'm a little grayer than I was. You saw my pre-pandemic headshot there. I think we're all maybe a little grayer. Some of us are a little hairier. One of the things I really missed during the pandemic doing talks like this, I really miss being in the room with all of you. I really miss the interaction. So I'm hoping we can try to have an interactive conversation through this medium. So I really want to encourage you to use that chat box. In fact, let's warm up right now. I'd love it if everybody could just jump on the chat. I'm going to pull it up. When you're doing a talk like this, I know it's different for a participant, but let me tell you, it's really different for a presenter. We can really easily have the feeling that we're just talking into empty cyberspace. So I miss seeing everybody. I miss seeing friends. I miss saying hello to people. So please, just type a few words in the chat. Let me know who's here. Say hello. I see Ronnie. Hey, Ronnie, it's good to see you today. I see Claudia's here from Clovis. Thank you for saying good morning, everybody. Thank you for giving me a little bit of that life support. It's really, really important. So please, Michael Lamb is here. Hi, Michael. Good to have you here with us today. Good to see some familiar faces. I wish I could say, at least I'm seeing some familiar names in the chat box. So thank you for that. And please do use this chat box to put in your questions during the presentation. I know what I think will work the best is if you have a question or a comment and you want to take the floor, I want to be interrupted. I prefer a more interactive conversation. So please don't make me just be a presenter. Please help me turn this into a conversation. Put your questions in there, and then our moderators will be watching for those questions, and they will take the responsibility to interrupt me at the right time, and then you will be able to unmute yourself and pose your question and get that conversation moving. So please help us out with that. And as you're going to more of these webinars, think of that. Your presenters really, we live off of that, and it's so hard when we're just talking to a screen in our home office. So really appreciate that. Good to see you all there. Thank you all for doing that. So much has changed in the pandemic, and so much has stayed the same. And if the pandemic has taught us anything, it's how unpredictable things can be. We can all look back on our plans in January 2020, and it's laughable how all of those plans just got scuttled. But we can only do more planning. All we can do is plan, even though that we know that we're facing an unpredictable future and we're not out of this yet. Let's talk a little bit about the future. Maybe in a year we'll look back on this talk and laugh at the things that I said were coming up. But that's all we can do. All we can do is do our best and plan as best we can with the information that we have. So what I want to talk with you today is about some of the things that have changed with HIPAA in response to the pandemic. Some of the things that have stayed the same with regard to HIPAA and with HIPAA enforcement, and what we might be seeing in the future. If you pay any attention to any HIPAA-related news, HIPAA has actually been in the news quite a bit lately. There's been a pretty significant increase in enforcement activity from the Department of Health and Human Services. They've been issuing a number of settlements or fines against covered entities just in the last quarter, mostly around patient right of access. Very interesting. We think of HIPAA as being all about data breaches. They've actually been issuing enforcement action against covered entities for failure to produce records that patients have a right to access. So that's been very interesting. We can't help but speculate and wonder what the new administration may mean for HIPAA and for HIPAA enforcement. I won't speculate about our new president, but if we just look at the new secretary of the Department of Health and Human Services, it is significant to note that he comes from a law enforcement background, and he's not unfamiliar with HIPAA. He made headlines in October of last year, issuing, in his capacity as Attorney General of the state of California, issuing an $8.9 million HIPAA fine against Anthem Insurance for data breaches. Anthem was hammered by the feds under HIPAA, but then they got the double whammy and got hammered by the California Attorney General under HIPAA. So he is not new to HIPAA. He is not new to this game. And he has shown us already, even before he started his new job, he's shown us that he's willing to issue enforcement action against covered entities over HIPAA. So I think we're going to see some changes. I think HIPAA enforcement has been a little bit quiet over the last few years, and I think we're going to see an increase in 2021. And I think that once we get through, with the light at the end of the tunnel, if we get where we all hope we're getting, and we get through our vaccinations and we start returning to a new normal, we're hoping in the summer, in the fall, I think that's going to be a trigger point for a lot of HIPAA enforcement activity, because there has been some relaxation of HIPAA enforcement, and that's going to go away. We need to be ready for that. Now is the time for us to start preparing for that good new normal that we're all looking forward to, making sure that we're ready for that. Now, as I said, some things have not changed under HIPAA, and we have to remember that HIPAA is not entirely about preventing data breaches. It's also about ensuring access. And sometimes we get so obsessed with locking down access that we fail to give access to the people who have the right to that access. Martin Luther said that when a drunk falls off a horse on the left side, it's a pretty sure bet that the next time he's going to fall off on the right side. So we've been working so hard to lock down access. We fell off the horse on the other side, and we've been not giving patients access that they are entitled to. And that's the enforcement action we've been seeing recently. Also, at the beginning of the pandemic, HHS issued some guidance, and they do this with every emergency. Every time there's a hurricane or an earthquake, they issue a press release to remind people that HIPAA does not mean that you have to keep patient conditions secret from their family. What we don't want, it's a nightmare that many people have gone through. Their family member is missing, their vulnerable family member, they can't get in touch with them, they don't know where they are. They're calling hospitals and emergency rooms trying to find their vulnerable family member, and they're being told by people with a bureaucratic HIPAA mindset, I can't confirm or deny anything about your elderly parent because of HIPAA. HIPAA has never been about that. That has never been required by HIPAA, and HIPAA gives a lot of leeway to medical professionals to exercise their professional judgment. When you believe in your professional judgment that it is in the best interest of the patient to share information with family members, HIPAA does not stand in your way. So HHS released some guidance on that. Again, this is nothing new. This has always been the case, and HHS has always been trying to educate people and make sure that they're not using HIPAA as a reason to not do our jobs or not help family members, not give out the information that's required. I didn't put a link in here because who wants links, but it's very easy to find online. If you just search for those keywords, you'll find some information about that privacy guidance. I want to pause there on that slide. I want to move into some of this enforcement discretion stuff, but I just want to pause and see if anybody has any questions about those privacy issues and those requirements to share information. You can trickle your questions in later if you think of something later on, and I'll be happy to jump back to that. So let's talk about some of the changes that have come from HIPAA. There have been some changes that came through very early in the national emergency, and there's actually been another new bit of guidance from Health and Human Services just in the last week or so. So I'm glad that we're here, and this is very timely, and I'm glad to be able to bring you the latest news from HHS on HIPAA enforcement. HHS announced that they were going to be exercising enforcement discretion. They were not going to be holding covered entities to the exact letter of the HIPAA law in certain cases. And they did this because they didn't want HIPAA to stand in the way of innovation. They didn't want HIPAA to stand in the way of new healthcare delivery models. They knew that the industry was needing to move quickly to serve patients and to try new technologies and new tools that maybe haven't been fully vetted by our IT departments, by our HIPAA security officers, and so forth. Didn't want that to stand in the way of patient care during this national emergency. Very much to the credit of Health and Human Services, prioritizing the human over the bureaucratic. So we were all very happy to see this come in. There have been two main areas where they've announced this enforcement discretion, where they're not going to penalize you if you don't meet the letter of the law under HIPAA. And the first came out last year, about a year ago. I think it was in February or March of last year, and that was around telehealth communications. So about using video conferencing technologies and so forth to deliver patient care. But they're not going to require all of the business associate agreement requirements that typically apply under HIPAA. We're going to get into some details there. It's important to note that this discretion applies to all telehealth services, not just telehealth services connected with COVID and with COVID treatment, but any telehealth service falls under this treatment, under this exemption. They want to make sure, they really want to encourage a broad adoption of new telehealth technologies. And a lot of people have been taking advantage of this enforcement discretion. We're going to talk about what that means. And then just in the last week or so, I think it was January 19th, they announced another bit of enforcement discretion regarding the scheduling of vaccines. Obviously, this is a huge logistical issue. How do we get people in? How do we find them, get them in here, get them scheduled, get them vaccinated, get them to come back, and so on. And HHS announced that for the exclusive purposes of COVID-19 vaccinations, they're going to apply similar enforcement discretion. They're not going to get bent out of shape if you use a web-based scheduling service to schedule your patients for vaccinations, and they're not going to hold you to those business associate agreement standards that would usually be required. So they're giving us the freedom to use some consumer grade technology that wouldn't normally be used in the delivery of healthcare, but being able to use those consumer grade technologies just because if that's the fastest way to get these efforts off the ground, we don't want HIPAA to stand in people's way. And again, if you want to find the specific guidance and dig into some of the specifics on this, we only have time to touch on the high points, but you can dig into it with these searches. Just go into your favorite search engine, and these search terms will pop up what you're looking for right away. So moving on. Really these requirements, what they're really about is the business associate agreement requirement. In general, when we're conducting telehealth and video conferencing and texting with patients, patient information, protected health information is being transmitted, stored, processed by these video conferencing services. And so a HIPAA business associate agreement is required. Same for scheduling. If people are going to a website and signing up for a vaccination, putting in their name, their email address, and their phone numbers, say that is PHI that's being submitted to this third-party cloud service on our behalf as a covered entity. So in order to do that, we typically need to have a business associate agreement in place with that third-party vendor. That's where that vendor gives us assurances that they're going to protect that data, that they're going to take steps to protect that data, and they're going to respect the privacy of that data. They're not going to use it, for example, for marketing purposes, which is what big tech does with all of our data, right? So we're asking these tech companies to not do that thing. By signing the business associate agreement, they're saying we're only going to provide this service and we're not going to use it for marketing. And we're going to have good security controls in place to ensure that it's less likely to be hacked. So that's the purpose of the business associate agreement. And now we're able to use services that provide the features that we need, that help us get these programs off the ground, but maybe aren't prepared to give us those assurances with the business associate agreement. But HHS is very clear. The way they word it is, we will not penalize you for using a vendor without a BAA, as long as you're doing it as a good faith effort to provide these telehealth services or these scheduling services. So that's what it comes down to, is what is a good faith effort to provide services. This is not a free-for-all. They didn't say do whatever you want, and they said there are still some guidelines, and I want to look at that with you all and make sure that we're following these guidelines for good faith efforts. So first of all, on the video stuff, telehealth in general, and this encompasses video, but it also encompasses text messaging and things like that. And they've specifically said, yes, typically we require a BAA here, but there's a bunch of consumer video conferencing technology that's become very popular that our patients have access to. Our patients may have ready access to these technologies. These technologies may be the easiest way to communicate with a patient. And during the national emergency, we don't want to put any friction in that patient communication relationship. So it's okay to use some of these services. And in their guidance, they specifically named a few services. And so all of these here on the left, these are all video conferencing services that at their consumer level are not generally considered HIPAA compliant, and these companies will not execute a business associate agreement. But HHS has said it's okay to use these services during the emergency for delivering telemedicine services. Some of these companies will never sign a business associate agreement. For example, Apple FaceTime, Facebook Messenger Chat. They will, under no circumstances, they have no product offering where they will sign a business associate agreement. So that's never been really a viable option for telemedicine under HIPAA. Some of the other ones, Google, Zoom, obviously, Skype, Microsoft Teams, those are organizations that have a HIPAA grade level of service where they will sign a business associate agreement. It's usually a more expensive level of service. So it's possible to get a BAA there, but some of them it's not even possible. Then over there on the right, they've talked about some real-time messaging solutions, some text message solutions that they recognized as acceptable during this time of the national emergency. They've been very specific that there are some services that are still out of bounds, and these would be any kind of public broadcasting, live streaming technologies. We're not going to provide patient care through TikTok, right? We're not going to provide patient care through Twitch, where it's a video feed that anybody can subscribe to. I don't think anybody is really tempted to use Twitch for patient care, but they wanted to be very clear. It's got to be access-controlled video conferencing, right? Not just something that anybody can sign up to for watching a broadcast. It's not. It needs to be one-to-one video conference technology, not one-to-the-world broadcast technology. So that's the guidance that they've given us there. And so what does it mean when they're asking us to apply good faith efforts? What are they talking about? And they gave us some examples, and they talked about what would be bad faith. What would not give you this safe harbor protection? What could put you at risk if you've decided to use some of these technologies? And the guidance here is actually pretty easy to meet. Pretty simple. They're not putting a lot of obstacles or burdens in here. They're very clear. Yeah, do not use these public-facing broadcasting tools. And then basically they don't want to see any fraud. They don't want to see this being used in furtherance of any kind of fraud or violation of any other rule. They specifically said, just because you're doing video conferencing with a patient doesn't mean you can take that patient data and use it for marketing. I don't think anybody here was really tempted to do that. So as long as we're doing what we already do, following the professional ethics that we already follow, following the good practices that we already follow, you're in pretty good shape dealing with video conferencing during the pandemic. So you're not too difficult there. So you don't have too much to worry about. If you've got doctors who are using FaceTime to talk to patients, I have clients who are doing this, who are using FaceTime, who are using Facebook Messenger and doing video conferencing. It's not uncommon. And right now, it's okay. We're going to talk about a little bit later about how to move into the new normal when it stops being okay. The good faith efforts required they do require and encourage reasonable controls. They want you to use these tools the best way that you can. Now, they didn't make this a condition of good faith. They didn't say that this is a checklist you must do in order to meet the good faith requirement. And they've specifically said that failure to do these things does not necessarily constitute bad faith. But do these things. Just do these things. We should be training all of our staff to be conducting their telemedicine visits in a private physical location. When we have doctors working from their home office, they need to be thinking about, are they in a private room with the door closed where they can't be overheard? During the summertime, we have to think about windows open. I live in downtown Albuquerque, and I have people walking by on the sidewalk. And sometimes I'll be having a business conversation, and it occurs to me, I need to shut the windows and speak in a lower tone of voice. So we just need to be thinking about those types of things. We've got to have those types of safeguards to limit incidental disclosures. And they specifically talk about speaking in a lower tone of voice, making sure you're in a private location, getting the patient's permission to continue, and things like that to help avoid the chances that we're being overheard. Turning on any available encryption technologies, and the great thing is that most of these video conferencing technologies have actually really excellent encryption already built in, but just making sure that those are on and available. Enabling privacy settings is also very important. Now, this is different from a security setting, right? The encryption is a security setting, but also look for privacy settings. We don't want to be using a service that makes a publicly accessible web page of our upcoming schedule, for example, and shows and lists all of the patients, and that could make that publicly accessible and available. So you want to look out for features like that might broadcast information about upcoming meetings and things like that. So just be watching out for those types of things. And then it's wise to inform patients, this is not necessarily the most secure method. Are you okay with proceeding with this, or would you prefer a phone call? Would you prefer an in-person visit if that's what we have to do? And most importantly, I really think it's important for us to have in our pocket, have that compliant solution already in place so that we can offer that to patients who are able to use it. So I don't think this should be a one-size-fits-all thing. So making sure that we have that fully compliant tool with the business associate agreement available for the patients who can use it and who want that extra protection. We're going to go into a little bit more about that a little bit later, about moving into the new normal. It's a little bit more complicated for the scheduling because the scheduling tools that are out there are maybe a little bit less mature than the video conferencing tools and maybe a little bit less savvy about security and privacy. So same sort of controls we want to see for online scheduling, making sure that encryption is all available encryption tools are turned on, making sure those privacy settings are available. But there's some other things as well. First of all, there's a requirement that we only use this for COVID-19 vaccinations, for scheduling COVID-19 vaccinations. So remember, the telehealth rule applied to all telehealth. This does not apply to scheduling any healthcare. This applies only to scheduling COVID-19 vaccinations. We're required to use the minimum amount of data to do the scheduling. That's probably just a name and a phone number and maybe an email address. There should be no reason to put anything in the scheduling system about pre-existing conditions or anything like that. So keep it to the minimum necessary data if we're using scheduling software without a BAA. We want to try to assure that the vendor is going to delete the data as soon as practicable. This can be tricky, and HHS has said, within 30 days, in no case later than 30 days. This can be tricky because these tech companies, they tend to get the data and hold it forever. So that's something you got to look for. And then this one is also extremely important and very applicable. You've got to have some kind of assurance that the vendor is not going to use this information for some other purpose, that they're not going to use it for marketing, they're not going to use it for research, they're not going to take this patient data that you're going to be sharing with them and using it for any other purpose. And what you're looking for here is you're looking at the standard privacy policy of the service that you're using. They've all got to publish a privacy policy, and they should say what they do with the data of the people who are scheduling appointments. Some of them absolutely use that information for marketing. I can think of a couple of services used for scheduling webinars, not necessarily scheduling one-on-one stuff, but for scheduling webinars where if you sign up for a webinar, you're on the email list forever, and you're going to get emails from till the end of time about other webinars that you might be interested in according to their algorithm. So you've got to evaluate these services for that. And HHS was really, really particular about this one. So if anybody here is interested in getting an online scheduling system for COVID vaccinations, I think there's a real need for it. We've really got to move fast, and we're going to need some innovation to get this working. But that's something that I really want you to look at those privacy policies for these services. And if anybody has any specific questions about that, I'd love to dive into some details there. So that's what we've been seeing so far in 2020 and the first part of 2021. Let's talk about what might be coming in the future. Again, planning is only as good as reality permits it, as it comes at us. But we've got to look forward, and we've got to think about what's going on. And the one thing that I'm most concerned about with this enforcement discretion that's been made available, I'm most concerned about the habits that we're all building at our organizations, the habits that our staff is building, and the habits that our organization is creating, the policies and procedures that are coming to effect at our organization, and how that's going to change, because this enforcement discretion isn't going to last forever. The enforcement is going to come back down in the coming months, we hope by the end of the year. So are we ready for that? Or do we have a bunch of people using a bunch of non-compliant software, and that's going to become a problem for us because we're not ready to shift them to the compliant solutions quickly enough when the enforcement and discretion ends. So we've got to, please.
Hi, pardon me. Lisa here. We have a couple of questions coming in from the floor. We have a question from Stetson about digital waiting room. He states, I assume they are similar to an in-person waiting room?
Right.
Stetson, if you'd like to unmute yourself, you're welcome to clarify that question if you'd like.
Yeah, so I'm just imagining using Zoom or, a lot of these platforms like the one we're on now, and a provider is maybe seeing a patient and they forgot to turn the waiting room on, or they had turned it off for a previous meeting, and then two patients end up being in there at the same time because one logged in early. And my gut kind of tells me, as long as you're not seeing a patient at the time, there's not as big of a deal because it's kind of like a waiting room in person. They're both kind of sitting there. But at the same time, my understanding is that a name is, HIPAA protected information, and they could have their name there. And I just didn't know kind of what the digital impact, or if there's anything specific to digital waiting rooms that you would like to add.
Sure. Thanks for that question. That's a great question, because there was a lot of heartache and worry about that, especially in the early days. There was a lot of press coverage. I'm sure you all remember about Zoom bombing, about people breaking in on other people's rooms. I mean, the good news is that the industry has responded a little bit, and the default settings are now available. There have been upgrades to these software packages to make that less likely to happen. So thank goodness for that. But yes, I actually agree that a digital waiting room is a lot like an in-person waiting room. And yes, people are going to see each other and they may hear names. These are all incidental disclosures that take place in an in-person waiting room. When somebody walks in and says, Mr. Martinez, it's time for your next test. These things happen. And as long as we're taking steps to minimize those incidental disclosures, they can be tolerated. They are disclosures, and you're right, it is PHI. Don't let anybody tell you that a name is not PHI. A name is PHI. But HIPAA recognizes that you can't possibly prevent every conceivable disclosure, and so it recognizes these incidental disclosures. And if somebody, I mean, in the absolute worst case, where you're in the middle of a sensitive, particularly sensitive healthcare consultation with a patient, and another patient bursts in, well, this can happen in the real life too, can't it? People can walk into the wrong room, and all of a sudden, in the middle of a consultation, somebody's walking in the room. What do you do in that case? The same thing that you do online, right? So it's not something that I think we have to be so panicked about. There was a real moral panic about this in the early days, but really we can just treat it the way we'd treat it as if somebody walked into the physical room. You would just do exactly the same stuff that you would do in that case. And I think that would be considered an incidental disclosure. And if you're responding correctly, it's not going to be a reportable HIPAA incident. We are required to take steps to minimize the likelihood and the impact of those incidental disclosures. So yeah, you should be having, the most important thing is we should not be reusing links from one patient to another. Each patient should get their own unique link, and that goes to just this one virtual room, one patient. So we should not be resharing that stuff. It's not a good idea to have a link for the doctor, for example, and all patients come to the same link for the doctor, because it's just so easy for somebody to click the link at the wrong time. So, so that would be an example of a reasonable safeguard to minimize those incidental disclosures. Very appropriate to do. It's definitely something that HHS would ask about. It's something that should be covered in a risk assessment. It's something that you should be looking at and considering during your risk assessment. So thanks for that question.
Great question. And Michael, we have another question coming in from Wendy. And her question is WhatsApp a viable way to communicate limited patient information within a private group of clinicians?
Thanks, Wendy. Another great question. And right now, absolutely. Right now, during this period of enforcement discretion, WhatsApp has been specifically cited as a viable method. Now, you're talking specifically about communications within the care team. So I think we should be thinking about that. And I think HHS hasn't talked about this, but I think we should be thinking about that very differently. What's appropriate for communicating with a patient is really going to be different from what's appropriate for communicating within the care team. The patient has, more limitations. We have more control over the environment within the care team. So moving forward, I want to warn you, WhatsApp will not be an acceptable method for transmitting PHI to anybody. And because you will not be able to get a business associate agreement with WhatsApp, with Facebook. Now, WhatsApp is actually pretty great technology. It's encrypted end to end. So it's virtually impossible for anybody at WhatsApp, anybody at Facebook to intercept these communications. But HHS has provided guidance saying even if they don't have the decryption key, they're still a business associate. Even though they can't access the data, they're still considered a business associate. And so they are a business associate. You're not going to be able to get a BAA with them. So that is not going to be a viable option for you when the national emergency ends. Personally, I would like to see some evolution on that point, because I do think that the WhatsApp end-to-end encryption is highly secure, and really it's basically compliant. I believe that WhatsApp is basically a conduit, that you should be able to conduct these messages without a business associate agreement. HHS does not currently agree. So HHS would consider that a violation of the business associate agreement standard. Again, something you can do now. It's definitely something you can do now. But again, this is something that you need to have in your risk assessment. This goes right into what we're talking about, this shadow IT. Do not think that this is a free-for-all, that everybody can do everything. You still want to be on top of this. You want to know what your people are doing. You want to know what tools they're using. You want to provide them with some guidance, not a free-for-all. Don't tell your users, just do anything. You don't tell your doctors, yeah, well, however you want to do it, that's cool with us. Provide some guidance. You know your patient population, you know your doctors, you know what your current technology capabilities are. You probably have an idea of one or two of these solutions that could be helpful. So provide some specific guidance. Let people know, yeah, we're gonna, during the pandemic, we're gonna go ahead and use WhatsApp, and we're gonna use Apple FaceTime or something like that, and try to keep it under control, right? Try to keep it limited. Try to provide some guidance around that. And you have to be, let's move on, Lori, to the next bullet point. And then you've got to be in communication with your users. You've got to know what they're doing. You've got to be talking to them and finding out what they're doing. And if you tell them, we're only going to use WhatsApp during this time, if a user comes to you and says, I'm having a problem using WhatsApp, I need to use Facebook Messenger. Okay, let's talk about that. We've got to hear what the friction points are, and we've got to set things up so that people can provide the care that's needed. So listen to your users, get that feedback, hear what's working, listen to what's not working, find a solution, but provide the leadership, provide the guidance on that solution. Don't allow just a free-for-all. And then whatever you decide to do, this really needs to be documented in your risk assessment. You really need to know, a big part of a risk assessment is just, what are the different systems that we use? How does PHI move through the organization? And if all of a sudden PHI is moving through WhatsApp, we need to know that. That needs to be documented in your risk assessment. And during the pandemic, you can say, well, this risk is being addressed well because of, one, the encryption, right? So that helps us with the security stuff. So we're not worried too much about the security stuff. And then from the compliance and the privacy point of view, we don't have a business associate agreement with WhatsApp, but the enforcement discretion gives us confidence that this is not a risk. That's what's managing the risk for us with our WhatsApp usage. And then be looking forward, that's going to change. That's going to change. Again, your risk assessment should be thinking about that. It's supposed to document what you're doing right now, but you've got to be looking forward. And the suspension of the enforcement discretion is coming, and that WhatsApp usage is going to suddenly become much riskier. As soon as the environment changes, that risk is going to go up. And that's the purpose of a risk assessment. So I really want to encourage everybody to conduct a new risk assessment, or an update to a risk assessment, or just an addendum, just an inventory of the systems that are being used. It's really important. Now's the time to get your hands around that and understand what people are doing so that you can be prepared for moving back to full compliance when that becomes necessary. Any other questions about specific tools? Wendy, I hope I answered that question well for you. I hope that gives you some guidance and some ideas of what to do next. So let's talk about where we're going to go from here. We've got to get back to a full compliance state. This discretion is going to go away. Nobody knows when, but it's probably going to happen quickly. We need to be watching for it and be ready for it. Well, let's hope that they're going to give us a heads up, but there's no guarantee. I think you really want to be ready to move on this as quickly as possible. So again, your starting point is that risk assessment. You have to know what's being used out there right now. You have to be talking to your users about that. And right now, I mean, actually yesterday, you need to have a plan for what is the tool that you're going to be using. What is the compliant tool? You should already have selected a video conferencing and text chatting tool that is secure, and you should already have a business associate agreement in place for that. And then speaking to Wendy's point, talking about communications within the care team, I think now's the time to move the care team to a compliant tool. We can't always control what patients have access to, how patients are going to work, what patients need. We have a little bit more control over what the care team is doing. And so now's the time to start migrating your team from WhatsApp to the new tool. It's going to take time to make that transition. It's going to take time to train people on that. People are going to fall back to their comfort zone. They're going to fall back to using WhatsApp. That's okay right now, but we've got to be building that up right now. I really think that we've got to start migrating them right now to the compliant tool, finding out where the friction points are, finding out what the features are that they miss, what do they like about WhatsApp, what's not available in this tool, how can we fill in those gaps? We've got to start building that now. You don't want to do that the day after the enforcement discretion goes away and you have to move in 12, you've got 12 hours to move. Start that process right now. And then likewise with the patients, let's gradually start moving the patients over to the compliant tool. Let's have that at least in our back pocket. And when we start a FaceTime communication with somebody, have that conversation with the client. Hey, I know we've been meeting for the last few months on FaceTime, but we're moving over. We have a new system and we want you to start moving over to there. Can I give you some instructions and show you how to do this? Can we have our next meeting on the compliant tool? And once again, finding out where the friction points are, finding out what works, finding out what doesn't work. It's going to take time to make this transition. So now's the time to start it. Right now is the time to start it. So number 5, finding those friction points. And moving on to number 6, I really want to emphasize this. Don't overcomplicate it. Okay, so back to Stetson's point. Don't freak out about the waiting room issue. All right, don't make patients log in with a password. Don't overcomplicate it and put up too many hurdles because you're so worried about those incidental disclosures. Put in reasonable controls, but really a link per patient, that's easy for the patient. It's super easy and transparent for the patient. It's also highly secure and very unlikely to lead to privacy problems. So don't overcomplicate it. Don't make it a whole thing. Ideally, I think we should be looking for tools that the patient can use from their web browser. Let's avoid making the patient install special software. Let's avoid making the patient create an account. Here's a link. Click the link. If you can click the link, you can come to your video conference appointment. And we've all got experience with this, right? We've all, every day, this meeting's on Zoom, that one's on Google, this one's going to be on Microsoft Teams, and we've all learned how to move from one to the other. But if we can avoid making the patients install special software, that's a great way to simplify it for them. So be looking for ways to simplify things, and don't overly freak out about those security things. And also don't let your IT oversell you the security stuff and say, oh, we need 2-factor authentication with a login and all of this extra stuff for the patients. Push back on that. Make it easy for the patients. And then finally, you've got to have a plan. Ideally, before the enforcement discretion evaporates, you need to have a plan for when you're going to finally move over 100% to the compliance tool. You want to enshrine this in your policy and procedure manual. You want to specifically ban all of the other stuff. You want to document that. You probably want to have a training session with everybody. And it's not enough to just say, okay, everybody, we're now using Microsoft Teams in an email. You want to explain to your staff why we're making this change. It's going to be a change to the way that they're already working. People always resist that. You've got to explain to them why we're doing this, and it's for the patient's sake. Don't talk about security, don't talk about privacy, and for heaven's sake, don't talk about compliance. We've had it up to here with compliance, and nobody wants compliance. But our doctors and our care teams, they do care about their patients. So put it in those terms. We're doing this to protect our patients, to honor their privacy, to respect the sensitive information that they've trusted us with. That's why we're doing this. That's what HIPAA is all about. It's not about compliance. It's about patient trust. It's about patient respect. Appeal to their sense of professional ethics. And you can get a lot further than making this a IT edict coming down from your HIPAA compliance department. And again, I want to emphasize this again, going back to the care team. All of this enforcement laxity, it's for the sake of the patients. HIPAA is, HHS is doing this because they want to ensure that our patients are getting the care that they need, and they don't want bureaucratic rules standing in the way of patient care. But I think it's different when it comes to the internal care team. I think it's different when it comes to our in-house processes. So bending the rules for the patients, that's just good customer service. But if we're bending rules for the staff, it's just sloppy IT. There are good tools available, compliant tools available. We've got to find them. We've got to implement them. We've got to set them up. It's going to take some work. It's going to take some work, but we've got to do this for the sake of our patients so that we can honor that trust and not slide into the new normal with sloppy IT. Let's talk just a little bit about the new reality here, work from home. Are we all? I think a few of you are at your offices, but a lot of us, I'm here at my home office. I actually shut down my office downtown over the summer, and I don't know when, if ever, we will go back to a physical office. We've all been adapting to this work from home environment. And you know what? I think this is the best thing coming out of the pandemic, and I hope we stick with it. I say all the time, the best thing about the pandemic is that no one ever again has to apologize for a child making noise in the background during a business meeting. No one ever again has to apologize for a barking dog during a business meeting. Turns out we're all human beings and we all have lives, and we don't have to pretend that we're just business robots having business meetings. So I love it. It's been fun peeking at everybody's living rooms and kitchen tables and so on. And I think that's a good thing coming out of the pandemic, and I hope we keep it. And also, I don't know what kind of feedback. I'd be curious. Folks, please type in the chat right now. I want to hear what you're hearing from patients, because what I've been hearing from patients and from my clients is that the patients love telemedicine. We've been dragging our feet on this for years. We could have done this, guys, we could have done this 10 years ago, and we've been dragging our feet on it. Not entirely healthcare's fault. The insurance companies have been forcing us to drag our feet on this. And now once the patients have gotten a taste of it, they are loving it. They much prefer it when the waiting room for their appointment is their living room sofa instead of your germ-filled waiting room with people coughing on them. They like it a lot better, and they really appreciate it, and it's working. It's working. So that's another thing that I really think we're going to carry over from this pandemic. And that's going to mean some changes to the way that we look at HIPAA. It's going to mean some changes in our IT departments. It's going to mean some changes to the way we think about cybersecurity and the security of our systems. The old school security model has been around for really more than a decade, and it's one that we're probably all very familiar with. It's really, we call it the perimeter security model. And it's a castle and moat concept. It's here's the clinic, here's the hospital, here's the admin office, and we're going to protect this, and we're going to lock it down, and the computers are in there, and we've got a moat around, and nobody can get in. We're going to protect our network. We're going to protect it with VPN. We're going to have intrusion controls. We're going to make sure that nobody can get into the castle. And this can be effective, but it also creates what we in the security business call crunchy on the outside, soft and chewy on the inside. If somebody does get through, if somebody does cross over the moat, there's a lot of damage that can be done. And now we don't have people working behind the moat anymore. We have people working from home, or really working from anywhere. That's the model that I want to get us to. That's the model that healthcare needs to go to. It's perfectly possible for a doctor to conduct a telemedicine visit from the golf course, from an airport, not just from home, from anywhere. So let's be thinking about a work from anywhere model, not just work from home, not just remote access, work from anywhere. And this shifts our focus. This shifts what we've got to look at in our security plans. So these are conversations you need to be talking about with your IT department. These are things you need to be considering in your next risk assessment. It really shifts the focus from the perimeter security, that moat with the castle, and it shifts it to the endpoint security. The endpoint meaning the workstation, meaning the laptop, meaning the mobile phone, the device that you're carrying around with you, the device that you're working on right now to join this meeting. We need to shift our security efforts to that device, and we need to protect that device. We need to lock that device. We need to protect the way it connects to our network, and then that device can work from anywhere. That device, ideally, there is no difference between working at the office and working at home. There's privacy considerations we have to have, keep the windows shut, be in a private room and things like that, because we're not supervising our staff. But from a technology point of view, the ideal situation is work from anywhere. The office stops being a privileged security location. You can work from anywhere. And this is possible. At the very beginning of, right as the pandemic was, it was before the lockdowns, but as we were starting to hear about this, I was working with some of my clients on their disaster recovery plans. And this was in February of last year. And we said, you know what? We should add something to our disaster recovery plan. How do we respond to a global pandemic? That wasn't in the disaster recovery plan. We had fire and we had tornadoes and we had earthquakes and we had all kinds of things, but we didn't have a global pandemic in our disaster recovery plans. And one of my clients had a fantastic, we wrote one sentence for the disaster recovery plan. In the event of a global pandemic, stay home. Just stay home and keep working. Nothing changes. Nothing changes, because working at the office is just as secure and just as effective as working from home. So some things that we've got to be talking with our IT department about is, let's restrict. I do think this is a good idea, making sure that our staff is using company devices only, devices provided by the organization. Let's avoid personally owned laptops and desktops at our home offices. They can be managed. It's possible to secure those. I'm not saying you can't do this, but in the long run, it turns out to be easier and less expensive to make sure that everybody's got a laptop they can take home. Our devices have to be encrypted. We have to have good, solid encryption at rest on all devices, all devices. Encryption is now, it's cheap, it's easy, and it's fast. We've got to deploy it everywhere. All of these devices that people are taking home, we want to make sure it's got an inactivity timer, right? That it logs out after a period of inactivity. Really simple stuff. We've got to be training our people on how to create good passwords, how to protect their passwords, how to use password managers. I've done a couple of other talks recently about passwords and password managers. It's something I'm very passionate about, and I love talking about passwords. It's so important. Many of our systems are protected only by a password chosen by an employee. So we've got to be talking about that more. We've got to be rolling out new technologies like multi-factor authentication. If we're letting people use smartphones, mobile smartphones, I said no personal laptops, but personal smartphones, harder to sell that to staff. People want to have just one phone. And also, good news, easier to manage. There's actually some really good mobile device management software that's out there that we can use to lock down those particular endpoints. And we can't forget about the privacy issues of people working from home. This is mostly a training thing, but also it's making sure that people have a dedicated home office where they can shut the door and that they're not conducting telemedicine in the living room while the kids are doing school in the dining room, things like that. We've got to start talking about that and thinking about that. And we also have to think about paper. Paper at home. We want to make sure that, at the simplest, is there a shredder in your home office? You must be printing a little bit of paper now and then, hopefully less and less, but we all probably have a printer and we're printing a little bit of PHI every now and then, so we want to make sure that people have a shredder there. And then this is also an opportunity to start thinking about outsourcing some of our services, going into cloud services. A cloud services environment can be extremely helpful, can really help you create this work from anywhere environment, because at the office, you're connecting to the cloud. And at home, you're connecting to the cloud. And it's the same workflow. Everything works the same. So be looking for opportunities to outsource your email, first of all, but also look for ways to get your EHR out of the office. Let's stop hosting our EHRs in-house on servers in the closet. There's lots of really good options for that. And if we look at the next slide, we actually did over at the PCA, where Bob is the CIO. I think that's your title, Bob. We actually did a presentation about how you can effectively outsource, reduce risk, and save money. So that's something that we've got a video recording of that I'd be happy to share with you if anybody wanted to look into that. So that's it. Let's see if there's any more questions. And I'm also happy to follow up with anybody afterwards. I'm very easy to find online. You can just search for me. My name is Michael Herrick. Please Please connect. Please let me know what questions you have. I'm happy to get on a call, get on a video call, talk through some ideas, talk through some things. Also, follow me on LinkedIn. We've just launched a new video series called HIPAA for Humans. It's realistic cybersecurity advice for human beings in healthcare instead of bureaucratic red tape jugglers. It's for humans, and we have a new video every Tuesday on LinkedIn. So what else? What other questions have come up at your environments?
So Michael, this is Lisa. We don't have any questions in the chat. However, would you like to invite people to unmute themselves and ask questions?
Please.
Okay. So yes, please feel free to unmute yourself and jump right on in.
We have just a few more minutes left before the top of the hour, and we definitely want to let you go on time, but please.
Well, Michael, this is Lisa, and fantastic presentation. Thank you so much for your energy. I have an odd question. It's a little outside of the realm of what we've been talking about, but it occurred to me. In the area of healthcare, we have certain diagnoses that are protected. That are, you have HIPAA, but then you have certain diagnoses that have additional protections, such as HIV or other conditions. And it crossed my mind, have you heard of any conversations happening around COVID being a protected diagnosis? Is that even in the realm of conversation? Any thoughts about that?
That's an interesting question, because yeah, there's sort of an inherent, every organization tends to have sort of an inherent risk profile based on the type of data they collect. And I always use dentists as the classic example of really low risk. If somebody breaches information at a dentist office, they found out I have teeth. All right, I'm just not that worried about it. So it's a very different environment from something like an HIV treatment or like an alcoholism treatment program or something like that. Or mental health, because unfortunately we still consider mental health to be a moral failing rather than a medical problem. That's sad. So that's a really interesting question. I mean, I can't imagine how COVID-19 could be considered good. We all know somebody now who's had it. But on the other hand, I do know somebody who's having a real difficult time returning to work because he had a COVID-19 positive test and now is unable to get a negative test. He keeps testing positive, and the Department of Health has told him, that's okay, you're not contagious, it's really negative, this is just how the test works. But his employer now is saying, you're not coming back to work until there's a negative test. And they're actually talking about what do you have to talk to a doctor? How are we going to make these decisions? So there are things like that. I haven't heard anything about that being a especially risky type of data, but I could see it becoming an issue.
It's kind of fascinating, and equally around the idea of whether or not people are getting vaccinated. And I don't want to take us down that road, but it's an interesting question for protected health information and how we might deal with that.
I can tell you this: I was at a grocery store, and I won't name the state. If I did, you wouldn't be surprised. And there was a sign that said, because of the Fourth Amendment and HIPAA, spelled HIPPA, because of HIPAA, we're not going to ask you why you're not wearing a mask, because that would be a violation of your HIPAA, HIPPA rights. And I didn't say anything, but I can assure you that is not a violation of your HIPAA rights.
Michael, this is Alberta Romero with the New Mexico Primary Care. I have a question on, now that a lot of people are shifting to working from home, in policies and procedures in your office, usually those are, centered on working in the office. Are they going to add in policies and procedures, people that are going to be working from home now that it's more like a hybrid? Do they have to change some of those procedures, or?
They really do. And what we're seeing is it's more than just a little tweak here and there. It's really a whole revamp. We're still figuring this out. It's not just a few new things that we do differently. It's really a whole new model. And in our policies and procedures, we generally treat working from home as a special exception that's only given to certain people, for certain specific reasons. And now we're really into a world where, everybody everybody can work from home. And so we've got to be looking at our policies and procedures. And I think we're going to be finding, I'm actually just getting into this with a client this week, we're really going to be finding that it's not just going to be tweaking the existing policy and procedure. It's probably throwing it out and writing something really quite new for this new model. This is a big change, and it definitely is going to require some policy and procedure updates. Thanks for that question.
Right. Well, I'll go ahead and just thank everybody so very much for your participation today. It's been a fantastic presentation. Michael, your energy is awesome. Your knowledge and expertise is greatly appreciated. And this video will be made available to members at the NewMexicoTelehealth.org website. And we also are doing these presentations weekly on a variety of different telehealth topics. So please feel free to join us again. Next week, we're having Jennifer Gruger on developing telehealth workflow for best possible patient and provider experience, another really important topic. And again, please check out the New Mexico Telehealth website at nmtelehealth.org. And with that, we will go ahead and close our session today and wish you all a healthy, happy rest of your afternoon. And thank you again, Michael. Wonderful to see you.
Thank you, everybody.
Take care.
Thanks, Michael. It was great as usual.
Thanks, Ronnie. Good to see you.
See ya.